This podcast is recorded in the land of the Kaurna people here in Adelaide. We pay our respects to the traditional custodians of the lands, waters and communities across Australia on which our members and trainees live and work, and to their elders past and present.
RANZCOG recognises the special status of Māori as tangata whenua in Aotearoa New Zealand and is committed to meeting its obligations as Te Tiriti o Waitangi partners.
Now we're going to move across to New Zealand and hear about working towards equity in sexual and reproductive health for women and girls in Aotearoa, New Zealand. I'd like to introduce Dr Anna Hudspith. Dr Anna Hudspith is a generalist O&G in the Hutt Valley, 20 minutes north of Wellington. She divides her time between this and a job in Wellington Hospital at the Regional Abortion Unit Te Mahu, where she has a special interest in surgical and later abortion care. She also co-chairs APGANZ, the abortion providers group of Aotearoa New Zealand, a charity, and the only national group specifically providing guidance and education in abortion. She also is a member of the Sexual and Reproductive Health Committee on the RANZCOG Committee and has recently sat as a guest in the Aotearoa New Zealand Committee. She has an appointment with the University of Otago, Wellington, and is an amazing advocate for sexual and reproductive health in New Zealand and Australia.
Ko Anna Hudspith toko ingoa. I use she, her pronouns. I'm going to speak to you today about sexual and reproductive health equity. I don't have any relevant disclosures. I would like to begin by acknowledging the traditional owners of the land on which I'm speaking from today, the people of Kaurna country. I'd like to pay my respects to elders past, present, and extend that respect to any Aboriginal and Torres Strait Islander people attending this conference today. I'd also like to recognise the special status of Māori as tangata whenua in Aotearoa, New Zealand, and the commitment to meeting our obligations as Te Tiriti o Waitangi partners. Now, we cannot have a talk about equity without first addressing the use of gendered language. This presentation is intended to be inclusive of all people who may require our sexual and reproductive healthcare, regardless of gender identity. I make note of RANZCOG's Gendered Language Project, and the QR code is up on the screen. Now, who am I? I am tangata tiriti, meaning that although I claim no Māori heritage, I am a person of Te Tiriti o Waitangi, and I'm on a continuous journey of learning and growing in Aotearoa. I am a silver spoon kid. I come from immense privilege. I grew up in central Auckland, which is our equivalent of inner West Sydney. I was privately schooled, and then I completed medicine through the University of Otago campuses in Dunedin and Wellington. I actually intended to be a GP obstetrician. However, the job didn't really exist anymore, so I very quickly did O&G. I met this guy at karate training. We both have black belts, and we have two daughters who are 8 and 5. I now divide my time between my journalist job in the secondary unit with my time in the Regional Abortion Centre in Wellington, where me and my clinical lead wear matching theatre boots that are sparkly. So why am I of any relevance to you? Well, those that know me will often introduce me as a passionate abortion and sexual health provider who does some obstetrics on the side to remain financially viable. Abortion and SRH care are where I have found my passion and my why, and it's probably why this is how I was introduced in a conference last year. SRH care is huge. It covers a range of topics. It is a human right. I think that for us at a system and a college level, SRH is the in-between. It's primary and tertiary and secondary. It's obstetrics and gynecology and general medicine. It's perinatal and it's postmenopausal. This care is often fractured and, sadly, often poorly provided. Along with this irregular and widespread land of provision, SRH is also the journey across that land, largely without a map. It is the mountains and the lakes. It is the ill-fitting shoes. It is the human side. We're going to talk about some patient journeys to examine a few of these journeys of equity. This is Ari. She's 32. She's due for her HPV self-swab, having had a cervical smear 6 years ago. It wasn't a great experience, but she's had 2 kids now, and she knows that she needs to take care of herself to take care of them. She lives in central Hamilton, a moderately sized city, and works as a secondary school teacher, and her partner runs his own business. They aren't extravagant, but they don't live paycheck to paycheck. Ari makes an appointment to see her medical practice. The next appointment's available in 4 weeks. It will cost her $75 for the appointment. This is a cost her family can absorb. What if Ari lived in Northland, where she worked on a remote farm? Her screening is overdue, but she can't leave the farm until the end of the season, and then she has to take a day-long round trip to see her GP. Her last test was HPV other positive, so she is recommended to smear this time too. She might have to absorb the cost of the speculum along with the consult fee. Given she is actually still enrolled in her old GP practice, she will have to pay an unenrolled patient fee on top of that. Now, we all know that cervical cancer is preventable. Cervical cancer affects Māori and Pacific Island people inequitably. While a smear is a good test, an HPV cell swab is a better performing test. However, a number of people still need a smear. For those affected by cancer that are Māori, the blue boxes on this graph, they are more than twice as likely to die from it. We do seem to be doing okay in our HPV vaccination, but we're not doing a good job with our screening. There's a 15% difference in the screening between our Māori population and other populations. As an article in the Lancet Oncology commented recently, and I'm going to quote because it says it so well, the low uptake of screening or medical visits among minority groups is often cited as a reason for health disparities worldwide. However, this reductionist view perpetuates injustices by implicitly blaming the individual while denying any underlying inbuilt structural causes for reduced interaction between patients of minority ethnicities and the medical system, thus diminishing any meaningful opportunities to improve the healthcare system for those groups. We are clearly not creating a system that facilitates our patients' needs. For example, despite being preventable cancer, New Zealand still has not fully funded cervical screening, and this was in the news just last week. Whilst the test itself might be funded, depending on location, the consultation and the speculum, if required, will often be passed to the patient. If you fulfil these criteria, you might have properly funded screening. But for so many New Zealanders, the cost prevents a significant barrier. I do not hear that we do fund screening for our Māori population, so cost is not our only barrier. So what are we doing to address this? One option is take the care to the people, do it where they feel safe. Buy a bus. Dr. Helen Patterson in the Te Waka Wahine Hawara bus attends A&P shows, Rotary events, and other community locations to offer a one-stop shop of HPV testing and immediate colposcopy the same day. They can also discuss gynecology issues, contraception, and sexual health. This started from the horror at a patient's 7-hour round trip for a colposcopy. The service is funded by grants, personal funding, fundraising, as well as some smaller contracts. Referrals are local or self. Some rural clinics occur monthly, and these are thought to save the community $100,000 in transport and accommodation. The key to its success has been the focus on going to ask the communities what they want and how they want it. Care close to home is also less stressful and better quality. Patients cope better, their kids can be there, and the opportunity and the appointment timing is often more flexible. Next up is Jodie, and she's in her first pregnancy, which was a surprise. She found out at 16 weeks and didn't manage to engage with care for several weeks after that. Jodie lives with her mum and is not with the father of the pregnancy. She presented at 31 weeks following a small bleed and also had some pain. A CTG was commenced and noted to be abnormal with a sinusoidal pattern. Her baby was delivered urgently and had marked petechiae and splenomegaly at birth. A postnatal diagnosis of congenital syphilis was made. Now, we all know that syphilis is increasing in many countries, largely among men who have sex with men, but there's a continuing uptick in people with the ability to become pregnant. Prior to 2017, congenital syphilis was rare. A public health briefing noted that in 2018 to 2020, we had more than 9 per 100,000 live births, increasing to 14 per 100,000 in 2022. Here is where we last released a national action plan to address the rise in this devastating disease. I want you to look at the navy blue boxes. These are our Māori population who are inequitably affected, being 71% of the case of congenital syphilis in the past 6 years. The Ministry of Health briefing in March of 24 noted that no or late antenatal care continues to be the most frequent and missed opportunity for prevention, accounting for 61% of cases of congenital syphilis. Now, I do want to point out that the inequity is not due to sexual behaviour, but due to inequity in access to early pregnancy and sexual health care. Once again, our system is failing to provide those for those who need it most. The unfunded sexual health guideline for syphilis noted the need for kaupapa Māori services and whānau-centred care services alongside culturally sensitive mainstream healthcare services. We're not providing the absolute basics. We need to go to the people. In 2024, Manatuhoro commissioned a group that I was part of to create the maternity commissioning framework. We wanted to build a maternity system that actually provided care with, within, and around communities, not at them. The real theme of this mahi is relational commissioning. This is used in social development, but surprisingly not in health. Here, you'll note there's a circle. There's no beginning and no end. We assess a need, we co-design the solutions, the key being co-design. We implement the solution in a functional way, we assess the implementation, and we evaluate and reassess. Here we want to create a model that empowers commissioners and communities to work together. This is currently sitting with the government and crucially awaiting approval and funding before rollout. Now I met Noah, who's a Takatapui person, who was assigned female at birth but identifies as non-binary. They sometimes experience intense gender dysphoria. They were originally planning a home birth with an LMC. However, now they're coming to the clinic because they have a new diagnosis of gestational diabetes and they need to commence insulin. Have a think about how Noah and their partner might be feeling. This is a more common consideration than most of us know. Trans, non-binary and gender diverse people are an important part of our population. They make up about 1% of all New Zealanders. A Conducting Ourselves survey reported that about 4% of transgender and gender diverse people had or would be pregnant since transitioning, which in an area that I work with about 5,000 people is 200 people. But a lot of us don't know we're looking after transgender people, probably because we don't ask or they don't feel comfortable enough to tell us. The Warming the Whare Ministry of Health commissioned work by Dr Parker et al. Painted a fulsome and sobering review of the available literature. Dr Parker provided 5 themes. Our transgender and gender diverse patients expect us to do a terrible job, and they armour up before they come and see us. They work hard to create a safe environment around themselves, which can be a really hard thing to do. At last year's ASM, one trans parent spoke about travelling to an entire different city to access ultrasound care that made them feel safe. Trans and gender diverse people face constant microaggressions and pervasive intersectional discrimination and cisnormativity throughout their journey. They advocate exhaustingly. Thankfully, we do sometimes get it right, and participants describe such relief when finding supportive care. Interestingly, the practitioners' results showed that most of us feel bound by institutional systems and resource restrictions. Most of us, myself included, often wait for the patient to lead. If they introduce themselves with a pronoun or use specific terms for anatomy, we will follow, but we don't start the conversation ourselves. Most of us have received little or limited education about how best to improve this care. Now, once you read Dr Parker's fantastic research, at least in New Zealand, you can sign up to the RANZCOG Warming the Whare Workshop Day. This is now run twice and provides small lectures and, crucially, role-playing and frank discussion to help understand, practice and finesse our inclusive care. Finally, you're going to meet Malia. She's 22 and at university in a loving relationship. She found herself pregnant unexpectedly after her contraception failed. She's 9 weeks pregnant and she wants an abortion. Abortion care in New Zealand is hugely inequitable. Malia should be able to have the option to choose if she wants a medical or a procedural abortion. Sadly, as abortion is another in-between service, options are dictated by what a service has cobbled together with what skill sets they have available. If she wants a medical abortion, she can obtain this via post. If she wants to see someone in person, it depends where she lives. This map shows the abortion facilities providing early medical abortion only, which is the green one just here, or providing some sort of surgical abortion, which is the red dots. Unfortunately, it doesn't tell us about gestational limits, timing, or staffing levels. Abortion is a time-sensitive procedure, and a few days rapidly become a week and then another week. Pregnant people can rapidly age out of their local area's options. As gestation increases, options decrease and inequity increases. This map's also in constant flux. There is no abortion workforce planning. Most providers are grandfathered in and apprenticeship trained. Many clinics are small and vulnerable to absence, illness, and fatigue. Community clinics are not necessarily integrated into hospitals. Misinformation is rife, with stigma and simply poor education and learning perpetuating these issues. Just in the last 2 years, exposed in a tertiary unit of 5,000 births per year, I have seen a woman with a terminal condition told she can't have an abortion at 18 weeks in my country. That's not true. I've seen a woman ask for an abortion at 6 weeks and not obtain it till over 22 weeks, involving 5 different regions. I've seen a woman with an incomplete surgical abortion have to drive herself to another hospital 2 hours away. I've seen another woman referred to a hospital 200 kilometres from her home for a first trimester surgical abortion because of lack of local services. and an inability to get IV access at the hospital that was closest to her home. A woman was told that she would need a psychiatric review and 2 MFM subspecialists to agree to have an abortion over 20 weeks, none of which is true. And this is only into the last 2 years. Our abortion service is unacceptably inequitable, and it causes unnecessary patient harm. Now, when I teach, I like to start from what a good abortion looks like. Abortion should be wherever the person needs it, as promptly as possible, and ideally early. It should be however the person wants it within reason, and it should be close to home. This should actually be how we provide most of our care, but it is even more important in certain groups of people. Of note, contraception is an integral part to full abortion care and sexual reproductive health care, and it has its own access and own funding problems. Now, if we go back to the map, what can Malia do? At 9 weeks, she can have a postal abortion or travel to one of these units. She might be able to access care in a single day, but unfortunately, most clinics will require more than one visit. At 12 weeks, Malia has much fewer options. Most hospitals do not routinely offer an inpatient medical abortion on a regular basis. We still have hospitals in New Zealand that refuse to provide any abortion care at all. If Malia wants an operative abortion, she's limited to one hospital here, maybe here, 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 and here. At 19 weeks, Malia can only reliably access a surgical abortion here, here, possibly here, and here. If she wants a surgical abortion over 21 weeks, she might get it here. She will get it here, but I'm 50% of that service. Now I'm going to try something. How many of you in this room can perform a laparoscopy or a laparotomy for an ectopic pregnancy? Thank you. How many can do a caesarean section? How many can do a ventouse delivery? Now, I'm going to do some maths. Please excuse my number crunching. It's very crude, but I'm trying to make a point. Now, if we take ventouse, about 10-11% of births require this. It's a standard sign-off for all obstetric and GPO training. In New Zealand, we've got about 86,000 pregnancies per year. In New Zealand, about 56,000 births. In the region where I work, we're going to be doing about 500 ventouses with 25 people covering call. It's about 20 each. We know that we do about 1,000 abortions in that area, and about 35% of those abortions are going to be surgical. It's about 15 each. Numbers are not massively different. Yet in this region, this is provided by 5 people, only one of which covers obstetric call, despite 3 being O&G specialists. Now, emptying the pregnant uterus confidently in an emergency is still not an expected core skill. Now, I'm not trying to say here that we expect all O&Gs to be abortion providers. Far from it. I would never expect my colleagues to do abortion they don't want to do. But how many people with unexpected pregnancy loss in your area in the second trimester would request a surgical procedure? Do you even offer it? What if they bleed acutely or request or have a dire medical contraindication to continuing their pregnancy? Is there anyone in your unit that can confidently empty the uterus in a hurry? We do have some online free abortion training, but it's really only first trimester. There's no funding for the care and there's no expectations for call. RANZCOG does have an abortion ATP, but this has never been completed in New Zealand. A request for funding with the government was declined. We've got altruistic funding for one trainee who might complete this within the next year. So are we working towards equity? Yes and no. We've clearly got a long way to go and many more challenges to undertake. Now I'm going to leave you with a Māori proverb. Kaua e mate whiki, mate ururoa. This is a Māori proverb which translates to, don't die like the octopus that gives up easily. Rather, die like the shark that keeps on fighting. Keep fighting your fight, whatever that might be. Thank you.